Hello everyone, welcome to Patho Excellence. In this endometrial pathology series, today's topic is AUB-O or ovulatory dysfunction. Endometrial pathology in ovulatory dysfunction reflects the absence of normal cyclic ovulation, and without the balancing effect of progesterone, estrogen drives unopposed proliferation, leading to irregular disordered endometrial patterns. Recognizing these changes is vital in cases of abnormal uterine bleeding and infertility. So, in this topic, we will discuss estrogen-related bleeding and progesterone-related bleeding. Here, estrogen-related bleeding, we will see proliferative with glandular and stromal breakdown, disordered proliferative phase, and atrophy. In progesterone-related bleeding, we will learn luteal phase defects, irregular shading, and abnormal secretory endometrium with breakdown of unknown etiology. So let's start with estrogen-related bleeding. Before we see different changes, annual and ovulatory cycles are associated with variety of bleeding manifestations, and mainly there are two types: estrogen withdrawal bleeding and estrogen breakthrough bleeding. So these are the most common patterns encountered in clinical practice. Now, what is estrogen withdrawal bleeding? What happens when there is estrogen is declining, or when there is reproductive age life is at the end? That means the menstrual cycle is shortened and there is the aberrant follicular recruitment resulting in shortened proliferative phase. So, ovarian follicles in this woman secrete less estrogen, and this fluctuating estrogen level might lead to insufficient endometrial proliferation with irregular menstrual shedding. And this bleeding is light and irregular spotting. Eventually, the duration of a luteal phase shortens and finally ovulation stops. So this synchronous endometrial histology with irregular menstrual shading and eventual amenorrhea result. Now, estrogen breakthrough bleeding. Here, anovulatory cycles have no corpus luteal formation. So, progesterone is not produced and endometrium continues to proliferate under the influence of unopposed estrogen. Now, this out-of-phase endometrium is shed in an irregular manner that might be prolonged and heavy. So this pattern is known as estrogen breakthrough bleeding and occurs in the absence of estrogen decline. Now, first pattern with the estrogen-related bleeding is proliferative with glandular and stromal breakdown. So, whenever there is estrogen-related bleeding, you will always see proliferative gland. No secretory change will be identified. So, here excessive fragmentation of glands and there is totally a breakdown of stroma. And few glands here show a proliferative phase. Some of these glands are fragmented, and here the tubular glands or weak proliferative glands are seen. Along with this, eosinophilic change in the gland is also seen, and stroma is totally collapsed. So this is proliferative with glandular and stromal breakdown. Now there are two types of appearance because of this estrogen effect. So whenever there is estrogen withdrawal bleeding, it is mainly due to sporadic anovulation. So there is rapid atresia of follicles and there is minimal endometrial proliferation. So what happens? Small amount of endometrium with poorly developed, weakly proliferative glands and stroma develops. So sporadic, occasionally there is anovulation and there is regression of follicle is rapid, which leads to this minimal endometrial proliferation. So here we can see some glands are in proliferative but having weak proliferative endometrium, and some isolated, these are isolated glands, and extensive blood and hemorrhage with scant stromal component. So this is a slide from the perimenopausal and ovulatory bleeding. Here, glandular and stromal breakdown is seen, and glands are minimally stratified, and rarely mitotic figures can be appreciated. So this is weak proliferative glands. See, again, these are the changes related to estrogen withdrawal bleeding, where you can find weak proliferative glands and stroma is collapsed and breakdown is there. Now, second change is chronic anovulation. So, sporadic and now chronic anovulation. So, what happens because of chronic effect? There is persistence of follicles and sustained unopposed estrogen stimulation. So, here excessive estrogen is there, and there is active proliferative glands and augmented glandular tortuosity. There is dilated venules in the subepithelial stroma, and there is often thrombus. And because of estrogen-induced epithelial changes, there is metaplasia, mostly ciliated as well as eosinophilic cell change seen in the metaplasia. And there is focal subnuclear vacuolization as a response to estrogen stimulation, but these changes are less than that seen in normal early secretory glands. So in sporadic, there is weak proliferative gland. In chronic, because of unopposed estrogen, here glands are actively proliferating. So here we can see proliferative glands, and here this ectatic or dilated vessel show thrombosis beneath the surface epithelium. Now this, when proliferative endometrium shows this breakdown in bleeding, this pattern is strongly suggests anovulatory cycle. So it means whenever there is proliferative endometrium with breakdown of stroma and gland, this is due to anovulatory cycles only. And this type of effect, same effect you will see in exogenous estrogen if patient is taking. So this is again similar picture here. Now the differential diagnosis of this proliferative phase endometrium with breakdown, it includes inflammation, polyp and leiomyomas. So in such cases, the presence of other features such as plasma cells in chronic endometritis or the dense stroma and thick-walled vessels of polyp establishes the proper diagnosis. Now let's discuss disordered proliferative endometrium. So as the name suggests, there is irregular proliferation. So here the growth of the glands and stroma exceeds that of the normal proliferative phase. Glands are irregular in shape, in width and distribution, and the lining epithelial cells are pseudostratified and form a dense row, and these nuclei are large and rich in chromatin, and mitosis are frequent. Now stroma is densely cellular and focally edematous. So irregular proliferation is a transitional form to simple or glandular cystic hyperplasia. Now, how will you differentiate it from hyperplasia? So the diagnosis should be reserved for the cases in which assessment is based on intact, well-oriented fragment of tissue, means we have to see the surface epithelial surface epithelium of the tissue fragment, and then we have to see the glands beneath this surface epithelium. And these abnormal glands should be focal, and the glands to stroma ratio must be 1:1. And glands are qualitatively similar to those in endometrial hyperplasia, but they are limited in extent and interspersed among glands with a normal proliferative phase pattern. So, whenever we see the section, we have to see whether this number of the glands are showing this disordered proliferative changes, and we have to see the glands to stroma ratio. So, if it is normal, then it is a disorder, proliferative endometrium. If it is increased, then we have to think of hyperplasia. And these dilated and proliferative glands are minimal in number, and they are admixed between the normal proliferative glands. So 2 points we have to remember. So this criterion helps to separate the focal disorder proliferative phase pattern from the endometrial hyperplasia, which is having more diffuse abnormality. So here we can see these are the proliferative glands. They are looking here, these are the normal glands, and these are the disorder proliferative endometrial glands. They are large in size and cystically dilated. But the number of the normal glands are more as compared to this cystically dilated gland. And the size of these glands are more than 2 times of the size of the normal gland. So this is disorder proliferative endometrium. Now what are the clinical possibilities and differential diagnosis? So first, excessive estrogen production from persistent follicles or polycystic ovaries with repeated anovulatory cycles, or ovarian stromal hyperplasia or ovarian tumors. Second, there may be absence of progesterone receptors in endometrium. And third, iatrogenic stimulation by synthetic estrogen. Now third change is atrophy. So atrophy is an important cause of abnormal uterine bleeding in postmenopausal patients. Now if they occur in reproductive age patient, then we have to think of premature ovarian failure, either idiopathic or due to radiation or chemotherapy for malignancy. So in atrophy, these glands are very scant in number, or there is scant tissue available for histopathological examination, and there is fragmentation of glands or surface epithelium. Very little amount of stroma here we can appreciate, and there is hemorrhagic blood clots, and this is stromal blue ball. So whenever we get this type of scant tissue, and if we are suspecting atrophy, then this minimal quantity of tissue should serve as a clue to the diagnosis, and it does not represent an insufficient specimen. So here the tissue biopsy is typically scant and consisting of only small amount of mucoid material composed of tiny strips and wisps of surface endometrium and detached fragmented endometrial glands. The epithelium here is low columnar to cuboidal and very small dark nuclei and minimal cytoplasm. Stroma is scant or absent. Mitotic activity is absent, and cystic change is seen in atrophic glands in hysterectomy specimen only, but not observed in biopsies because of tissue fragmentation during the procedure. Now, second is progesterone-related bleeding. So here there are 3 abnormalities we can detect. One is luteal phase defect. Second is irregular shading, and third is abnormal secretory phase, not otherwise specified. Now, overlapping morphological features between biopsies obtained from patients with luteal phase defect related bleeding and those with abnormal secretory phase, not otherwise specified. So all these terms are descriptive and not diagnostic. Now what is luteal phase defect? So here what happens, ovulation occurs, but corpus luteum is functionally inadequate. So there is regressing corpus luteal very early and producing inadequate progesterone, or the endometrium fails to respond it. So this causes either infertility or non-menstrual secretory bleeding. So, in the infertility setting, the histologic dating of the endometrium is required and luteal phase defect is a clinical diagnosis. So, in the AUB setting, glands appear secretory but do not match any one date of the cycle in that they are straight or abnormally dilated. Pre-deserialization is suboptimal. Breakdown is variably present before menstrual phase. So there is no matching between the appearance and the proper menstrual date. So lag of this histologic endometrial date of 3+ days from actual post-ovulatory days is there. So must be found in 2 consecutive cycles to be clinically significant. So will you see what will you see in luteal phase defect? Here we can see secretory glands are there. Some of are having vacuolization, supranuclear, some of having subnuclear, but there is compact and hemorrhagic stroma and stromal breakdown. So, though this is secretory change, instead of edematous stroma, here we can appreciate compact stroma. Now, second is irregular shading. It is attributed to persistent corpus luteum with prolonged progesterone production. So, this term is restricted to the bleeding caused by true ovulatory dysfunction. So, one pattern of irregular shading yield a mixed phase pattern where we find secretory and proliferative endometrium, and their diagnosis is reserved for those specimens in which there is a mixed pattern of secretory and proliferative glands at least 5 days after the onset of bleeding. So, even after 5 days of onset of bleeding, there is mixed pattern where we find secretory as well as proliferative glands in a single endometrial biopsy. So, irregular shading is also manifested by regular secretory phase development in which multiple phase of secretory endometrium means early, mid and late are present. So breakdown and bleeding with glandular and stromal collapse is present, usually focally but occasionally in a diffuse pattern. So what are the patterns we here find? Either secretory and proliferative mix or early, mid and late. 3 patterns are mixed in a single biopsy sample. So here irregular shading in which proliferative endometrial glands in one area with stromal breakdown and hemorrhage, and here we can find secretory gland with stromal collapse and areas of hemorrhage. So secretory glands and proliferative glands in a single biopsy. Now, inadequate secretory phase. So here in deficient secretory phase with coordinated apparent delay, the functional disturbance is preceded by persistent follicle with irregular proliferation and late ovulation. So the secretory changes that are induced by ovulation are therefore only apparently delayed and not delayed in relation to the day of ovulation. So part of the glands are cystically dilated and others narrow and only occasionally slightly convoluted. So here the glands are dilated cystically, but the convolution is little bit. The glandular epithelium show the beginning of secretion with basal glycogen vacuoles and slightly rounded nuclei corresponding to the second day after ovulation in a normal secretory phase. And the stromal cells are spindle shaped or large and separated by focal edema. And spiral arterioles are present and only underdeveloped focally. So this is inadequate secretory phase. That means the secretory phase is not properly developed. Now, abnormal secretory phase. So, abnormal secretory phase or this inadequate secretory phase are same. What we will see here, the glands with secretory changes such as basally oriented nuclei and vacuolization and the absence of mitotic activity. Glands are tortuous, but stroma is dense. That means lacking edema or predecidual change. So the endometrium in such cases cannot be assigned to any histologic day of the normal secretory phase of the menstrual cycle. And there is always glandular and stromal collapse, presence of stromal blue balls and eosinophilic syncytial change. These all changes we have seen in our earlier episode 4. So that you have to keep in mind whenever you see this type of picture, there is that is called glandular and stromal breakdown. And with early breakdown, tortuous secretory glands often show star-shaped outline. So these are the secretory glands showing star-shaped outline, and this is abnormal secretory phase here. Though glands are secretory in phase, the stroma is that having a dense appearance and little edema compared to the normal secretory phase. Here also the glands show secretory changes with basal nuclei and vacuolated cytoplasm. These are the small and tubular glands rather than tortuous, and stroma is dense. So this is again an example of abnormal secretory phase. So here we can appreciate secretory glands are there. Some are small and tubular, few are cystically dilated, few and stroma is focally edematous. Here the star-shaped glands with dense stroma. Now we have discussed estrogen-related and progesterone-related and ovulatory or abnormal uterine bleeding. So what will you write when you see these type of changes? So the report should address the presence or absence of morphological changes of breakdown and bleeding, as well as any specific lesions if present. If the pattern is that of proliferative, that means it is an ovulatory cycle. So a descriptive diagnosis such as proliferative endometrium with glandular and stromal breakdown offers a precise morphologic interpretation of the anovulatory bleeding pattern that often is sufficient for clinical management. So whenever we find proliferative gland with changes of breakdown and bleeding, we have to write down proliferative endometrium with glandular and stromal breakdown, and it is suggestive of an ovulatory cycles. Now, if the changes show non-menstrual secretory endometrium with breakdown, but these are not diagnostic of a defined luteal phase abnormality, so at that time we have to write down irregular secretory endometrium with glandular and stromal breakdown. So this will communicate the observation of an abnormal yet benign appearance while not assigning definite morphological etiology. So in general, a comment regarding the absence of other possible causes of bleeding such as hyperplasia, inflammation, pregnancy, polyp is most useful in addressing specific clinical concern. So this is about estrogen and progesterone related abnormal uterine bleeding. Now, next topic we will discuss pregnancy related changes, hormonal therapy effect, and endometritis. So in summary, Ovulatory dysfunction disrupts the normal cyclic pattern of endometrium, leaving behind irregular proliferative and sometimes hyperplastic change. So recognizing these features is key to linking pathology with abnormal uterine bleeding and infertility. So always remember the hallmark is the absence of secretory transformation. If you found this helpful, don't forget to like, share and subscribe for more pathology insights and join our Telegram channel for detailed updates. So thank you and stay tuned.